Okay, so okay, so you know about kidney, and usually when we talk about kidney, we say that it's a bean shaped, and when we talk about bean, we say that it's a kidney shape. So it has a very peculiar shape, kidney, right? So this is the outer one is cortex, the inner one is medulla, and the outer surface is smooth, dark brown, and shiny. Smooth, dark brown, and shiny. If you have a kidney in your hand with smooth outer surface, shiny, dark brown, means you are handling a very, very normal looking kidney. Because the diseased kidney is little shrunken, irregular, granular, not that much shiny surface. Okay, so normal kidney, outer surface is smooth, shiny, dark brown. The outer area, this is called cortex. The inner one is called medulla. And then we have callisis, renal pelvis, and the ureter. So we'll go one by one. If you start from here, this is renal vein, this is the renal artery, this is a renal calyx or callisis. So there are 6 or 7 callices. They merge to form the pelvis, and then it joins to the ureter. Now, if you see about the artery, it goes in and they form the segmental artery, this one, till here. Then it forms interlobar artery from here. And then it forms the arcuate artery. From this arcuate artery, the interlobular arteries goes out. And these interlobular arteries go and join the globulus. So each of the globulus is being supplied by the globular artery as an efferent artery. Please kindly remember that in kidney, in the globulus, the blood supply or the artery which is coming in is called afferent arteriole, and which is going out is called efferent arteriole. Still it is arteriole. It's not vein. And the same efferent which is going out comes down and then it supplies the tube. So just imagine that tubules is getting blood supply after it has been passed through the whole globule. So the tubules are morely susceptible for stimulation. But nature has provided these tubules strength of developing quickly after suppose any ischemic. So it hardly takes days to reform a new tube. if there is tubular. So when we will be discussing tubule, we will look at it. So after just like this, the vein start. So this is arcuate vein, then this is interlobar vein, then segmental vein, and finally renal vein. Then we have renal column, this one. And this renal column typically it holds the paramedic column. Then we have renal pathway. So all the tubules they converge here and collect urine here. And then we have renal balance and urine. So this is the basic fundamental structure of it, right? Should I move? Is it okay for you? Now, if you see under microscope, you see kidney like this. This is a lobar in which you see one glomerulus, second glomerulus, third glomerulus, fourth, right? So these are a rounded structure. They are glomeruli, multiple. Surrounding this glomeruli are tubules. So tubules which are approximating the glomerulus, they are called proximal tubules, right? And away from it are the distal glomeruli. Clear? Now, in the glomerulus, this is one glomerulus. We have this is a parietal epithelium, which is forming a Bowman capsule. This is Bowman space where the urine start collecting, right? And these are capillary duct. So what we will do, if you see under microscope, we have four things in a kidney which we have to discuss. Four. Number one is glomeruli. So whenever you see a biopsy of a kidney, you have to tell them how much glomeruli you are looking at. For example, you got two pores of kidney. Usually, the kidney biopsy come to us in the form of pores. So we have a specialized apparatus like a gun, and we put it here, and then we push it. So the needle go in and comes out, bringing a core of kidney biopsy. So usually we ask for two pores because we need to have adequate biopsy. And what do you mean by adequate biopsy? It means we have to have a good amount of glomeruli. If suppose a surgeon sends you biopsy with having only one glomeruli, glomerulus means one, glomeruli means two, and a few, and it is very difficult for you to have. So you have to have at least 10 to 12 glomeruli to make you diagnosis. Because in FSTS, some of the glomeruli appear to be normal, and some of the glomeruli are reasonable. For example, a single glomerulus which you see is normal one, so you cannot diagnose that until you have number of glomeruli. Okay, number one, glomeruli. So when you write a report, so you write glomeruli, and then you start that. In the core, two cores of the biopsy, we have 8 glomeruli or 10 glomeruli, whatever you see. And then you start writing the structure of it. Number one. Number two, tubules. So you see the tubules. Now in this biopsy, do you see any space between the two tubules? Hardly, no. So this shows that the kidney is in a perfectly normal condition. In abnormal kidney, there is a space between the tubules. So when we come there in the disease process, I'll show you how you have fibrosis and inflammation in between the tubules. Number two. Number three is interstitial. The space between the tubules are called interstitial. Here you don't see any gap between, right? Basically, this is interstitium between tubules, right? And the fourth one is blood vessel. So in your biopsy report, you start mentioning each and everything separate. Glomeruli, tubules, interstitium, and blood. This completes your whole report. Now, this is electron microscopic picture of a tuft of one glomerulus. This is one glomerulus. These are all capillaries, right? Now, if you take a section of it, so this is one capillary. This is endothelial cell, which surround the inner side of the capillary. Endothelial cells have penetration, right? Then you have basement membrane. After basement membrane, you have epithelial cell. Which epithelial cell? It's a visceral epithelium. It is closely connecting the capillary. The parietal epithelium is bounding the one capillary. So it is only present in the outer portion of the glomeruli or glomerulus. For example, this is the parietal epithelium, right? It is outside. Inside, it's not visible here, but inside, if there is epithelium which is closely connected, the outer portion of the capillary is called visceral epithelium. Now, this visceral epithelium has food process, which is called podocytes. Okay? Clear? This is very important because if you understand the basic of this kidney, then all the diseases will be easier for you. These are all podocytes. Now, podocytes sit like in such a way that there is a gap between the food processes. And this gap from the outer side allows the fluid to come and go out. Clear? Now, outer side it is podocytes, output processes. Inner side, these are fenestration of the endothelium. So endothelium is also allowing some of the fluid to pass by, and podocyte is also allowing some of the fluid to go out. Not all. Okay. Now, this is even the high power. We have taken a section from here. This is the basement membrane. This is endothelial surface, inner side. This is the outer side, and these are podocyte, and there are slits between the food process. Here. Okay, now this is a diagrammatic picture of the same thing to explain very important. Very important. Four capillaries. They are held together by mesangial cells. So mesangial cells in the glomerulus are the cells which are holding a group of capillaries. So in one glomerulus, there are different groups of capillaries. Just for example, they have taken one. But it is not one. There are multiple different groups. They are being held by mesangial cells. So there are one or two mesangial cells normally present. Two. Maximum. Here there are two. They are holding this capillary, this one, and this one. Now this is endothelial cell with fenestration. This is epithelial cell with food processes. Visceral epithelium, not parietal. This yellow color is the parietal. Don't confuse that. In parietal or one glomerulus, it's a they have tried to show you one glomerulus, but basically in one glomerulus you have multiple such type of. It's just an example because they have bounded this with this parietal epithelium, looking as one glomerulus, but usually you have multiple such type of bonds. This is one, right? Bounded by resonance cell, right? One resonance cell, two resonance cell holding these four groups. Then again, you have another four capillary. Again, you have mesangial cells which are holding these, right? So just like this, 1, 2, 3, 4, and then you have a parietal epithelium which is holding all of this as a globular. Is it clear now? This is only this part, right? Clear? Now. The important thing which is you should remember that each blood vessel has a basement membrane. Now this basement membrane starts from here, encircle the whole capillary, and then reflects on the mesangial cell and go towards the other capillary, like this, the outer side. Again, it is not going back here. So the inner side of each vessel is without basement membrane. Okay? Clear? The basement membrane is only and only covering the outer portion, like this. And it reflects and moves on the mesangial cells and again going to the other capillary. Again, reflects on the mesangial cell, the third capillary. Then again, so the inner portion of each of the capillary is without basement membrane and it is supported by mesangial cell. So what happens that in some of the disease, when there is mesangial cell proliferation, what will happen? What will happen? The cell is expand, the mesangial cell, and this tip starts going in between the endothelial cells and the basement membrane. That is called splitting and interposition of the mesangial. Interposition means it is splitting the endothelial cell with the basement membrane and it is going in between. When you will be discussing that, try to remember this picture, which is mesengiocapillary glomerulonephritis, in which mesangium proliferates and then it goes in between the endothelial cells and basement membrane. This is called interposition of the mesangial cell. Clear? So basically, the inner side has no basement membrane, and the mesangial cell, if it proliferates, it has an opportunity to go in between this area. And so much so that it completely encircles the capillary and forming a false basement membrane. So you have then two basement membranes. The true basement membrane and a false basement membrane. And it forms a strong tract appearance. Please kindly understand this important. This parietal epithelium, when it proliferates, it forms crescent. So crescentic glomerulonephritis or rapidly progressive glomerulonephritis appears when parietal epithelium starts proliferating. So it proliferates and starting squeezing the whole glomerular. Parietal. The crescent formation is only been developed when there is proliferation of parietal epithelium. So the parietal epithelium, which is present in the bovine capsule, it proliferates and forms a crescent. And as it grows up, it slowly and gradually squeezes the whole glomerular tuft, and a time comes that there is no glomerular cavity. We will discuss today. So it will be here today. Clear? Any question regarding this one? So we have mesangial cells, we have capillaries, we have food processes. This food processes is because of the visceral epithelium, which is of blue color. Remember, blue color, visceral epithelium. Parietal epithelium is yellow color. And when there is proliferation of parietal epithelium, there will be crystal formation. Okay? Crystal formation can never happen with the proliferation of this. Okay. Now coming to the glomerular diseases or glomerulonephritis. Today we will be discussing about the acute one. Tomorrow we will be discussing the chronic or nephrotic syndrome. Today we will be discussing nephritic first. Okay, so there are some clinical manifestations that you should know before proceeding towards any of the entities. Now they are acute nephritic syndrome, rapidly progressive glomerulonephritis, then nephrotic syndrome, then acute renal failure, then chronic renal failure, and then asymptomatic hematuria or proteinuria. These are the clinical conditions by which the patient comes to you. And as a doctor, you have to look after these 6 things to treat the patient. Sometimes a patient comes with asymptomatic hematuria and proteinuria, and when you investigate, it's nothing. So that's why this separate entity has been created. Some of the people, they have hematuria or proteinuria without any abnormal, seriously abnormal, slightly. Okay. Okay. Starting with acute nephrotic syndrome. Assalamualaikum. Good morning. So your lecture is at 11 o'clock in female theatre. It is just above the foot process, the foot court. So there is a ramp there on the back side. So if you come up, you will be there. I'm in a lecture now. So after just finishing my lecture, you will be here. Okay, thank you. Bye. Dr. Ramani is a very nice clinician, and he will be taking lecture after this. Nephritic syndrome, as the name says, is acute onset of usually grossly visible hematuria, number 1. And blood cells in urine, mild or moderate proteinuria, mild to moderate, not severe, and hypertension. So you have 3 important things in nephritic syndrome. Number 1, hematuria, proteinuria, and hypertension. And this is basically a classic presentation of post-streptococcal glomerulonephritis. When we were students like you, we were just told that this is post-streptococcal. But now we have seen that it's not only the post-streptococcal glomerulonephritis, but there are other diseases which can also cause such an entity. We'll discuss. Then rapidly progressive glomerulonephritis, when the same thing deteriorates, characterized by nephritic syndrome with a rapid decline in the GFR, rapid decline, which is hours to days. Suddenly you see that blood meter nitrogen is increasing and patient is developing uremia. So this is rapidly progressive. And this is also seen in presenting type of glomerulonephritis. We'll see just today. Then nephrotic syndrome, third one, characterized by heavy proteinuria. Here it is mild to moderate. Here it is heavy proteinuria, more than 3.5 gram per day. 3.5 gram per day. Hypoalbuminemia, when proteinuria is excreting out, the blood albumin level will decrease. So hypoalbuminemia, severe edema, because the oncotic pressure is less, so the fluid is going to accumulate in the extremity. Okay. Hyperlipidemia, to compensate the oncotic pressure, liver start producing more and more lipid. Then lipiduria, the when the lipid concentration increases in the blood, that will also come in the lipid. So there are five important things: proteinuria heavy, hypoalbuminemia, severe edema, hyperlipidemia, and lipidemia. This is nephrotic syndrome. Fourth one, asymptomatic hematuria or proteinuria. Some of the patients, they have combined manifestation or a subtle mild glomerular abnormality. So mild one, and they start secreting some of the protein or some of the blood hematuria protein. Then acute renal failure, dominated by oliguria or anuria. What is oliguria? Less amount of urine. Anuria means absolutely no urine. Recent onset of azotemia. What is azotemia?
Increase nitrogen in urine.
What is the difference between azotemia and uremia?
It's just failure, renal failure.
Any good example? Difference between azotemia and uremia? Both of them has increased BUN, blood sugar level. But the difference is, in azotemia, there is no silent symptom. But in uremia, it is with the silent symptom. Azotemia, it can result from glomerular interstitial or vascular injury or acute tubular injury. Then we have chronic renal failure, characterized by prolonged sign and symptom of uremia. So that same azotemia now has become uremia because they are producing sign and symptoms. So usually, end result of all chronic renal parenchymal diseases ends up with chronic renal failure. We'll discuss this thing tomorrow. Clear? No problem? No. Now, pathological manifestations. Either we have cellular proliferation, and this cellular proliferation will be either meningeal, endothelial, or epithelial. If I'm saying epithelial means visceral epithelium, no parietal. Okay? Then leukocyte infiltration like neutrophil, monocyte, and sometimes lymphocyte. Then crescent formation, proliferation of parietal epithelium. Now we are talking about parietal epithelium, yellow color epithelium, which is bounding the human flesh, right? When those cells start proliferating, they form a crescent formation. And also with the infiltration of leukocyte. Then thickening of the basement membrane and hyalinization and sclerosis. So these are the manifestations which we see in the kidney. Pathogenesis, either there is antibody against inherent glomerular basement membrane, means antibody is directly attacking the basement membrane. Whole of the basement membrane become antigenic. Or antibody against planted antigen. Antigen, wherever it is, they come floating and they are stuck in the glomerular basement membrane. And antibody then go and attach to those ones. That is called a planted antigen. Number two. Number three, trapping of antigen-antibody complex. So wherever there is antibody-antigen complex, they go in the blood, and every blood has to pass through kidney, so they go and deposit it in the kidney. Antibody against glomerular cell like meningeal cell or monocytes, or cell-mediated immunity like synthesized T cell as well. Now, important thing in these one, when there is antibody against inherent glomerular basement membrane, and if you see under immunofluorescence microscope, there will be a linear deposit of iron. Linear deposit. Antibody planteds as well as antibody complexes, when you see immunofluorescence microscope, there will be a granular deposit of this antibody. So let's go on and see what's going on. This is the first one in which the whole glomerular basement membrane become antigenic. So these are the antibodies. When they go attached here, they form a linear pattern, linear, smooth pattern, because the whole of the basement membrane itself becomes antigenic. The other one is these are planted one. When the antigen go and attaches here, and the antibody when they come and attaches with this antigen, they form a granular attachment. Means haphazard type of accumulation of antigen antibody. Yes,
And the picture see this considered as subepithelial.
this is subepithelium. Yes. Because this is epithelium, and whatever it is here, they are subepithelial deposits. And then antigen antibodies are formed here. Now the third one here is both. This is subepithelium as well as subendothelium. So these are the circulating antigen antibody complexes, and they go and settle wherever they want. This is subendothelium, this is subepithelium, and some of them are in the basal membrane. Again, to do IMF, they will show a granular type of deposit because large one here, less here, larger here, less here. So a granular pattern. Here, it is a continuous pattern. So they are called a linear type of deposit. Again, haphazardly, more, less, more, and less. So if you do the immunofluorescence stain, you look like a granular appearance here, appearance of this one and this one. This is granular and this is linear. You see how clearly well formed basement membrane shining. So this is called a linear type of deposit. You only see this thing where you have inherent anti-glomerular basement membrane antibody. Here, you are following me, right? You are with me. So these are the basic things, and when you understand this thing, everything becomes clear. Okay. Now these podocytes is important. Podocyte is formed by which epithelium? Which cell? So upward processes are being formed and a gap between 20 to 30 nanometer, and they allow, and there is a pore. This is inside the capillary, this is basement membrane, this is outside capillary. So these are podocytes with the slits between. These are the fenestration of the endothelial cells, and these are basically a distance of 20 to 30 nanometer gap, which allow fluid to come from this area to outside, and they have specifically a polycanonic surface fluid, so it does not allow every fluid to go out. So there is a check and balance. So it allows some of the fluid to go and some of the fluid not to go. Okay, clear? Mediators, neutrophil and monocytes, macrophages, T cells, and NK cells. So these are inflammatory cells which are mediating this process. Platelets, mesangial cells, and soluble cytokines and chemo. So these all basically are contributing to this pathological process. Now coming to the first topic, which is post-infectious glomerulonephritis. When we were students, we just called it a post-streptococcal glomerulonephritis. Now it is called post-infectious because now we know that it is not only the streptococcus which is causing such a disease, but there is a list of other diseases which we will discuss later on. So we are calling it post-infectious now. But we will consider post-streptococcal to make you understand. And this post-streptococcal will follow all of the features later on. What happened here? There is diffused proliferation of glomerular cells with influx of leukocyte caused by immune complex. So immune complexes are there, which is deposited probably beneath the visceral epithelium to form a heart. There will be hematuria, azotemia, oliguria in children following group A beta hemolytic streptococcal infection. Okay. So they are also called, old term is post-streptococcal glomerulonephritis, which is now we don't use. There is hypercellular glomeruli. So you have seen a normal glomerulus, how it looks like, but when it becomes diseased, it becomes hypercellular. Means there is proliferation of endothelial cells, proliferation of epithelial cells, proliferation of mesangial cells, plus infiltration of mucous cells, mostly neutrophils. But you can have also monocytes. So increased endothelial and mesangial proliferation, some epithelial also. There is IgG, IgM deposit and C3, but not IgA. So IgA will not be there. IgG and IgM and C3 along the glomerular basement membrane. Now, most frequently in the children at any age, but the specific peak age is between 5 to 20 years of age. Male and female ratio is 3:1. Frequency is developed country is declining because the hygienic condition of those countries is very good. So now they don't have these type of diseases. Still, the poor countries, we have such a disease. A major cause of acute nephritis in developing countries like Africa and Asia is still facing this problem. But the important thing is, even if the person develops post-streptococcal glomerular nephritis, 95% they recover fully without any problem. If you treat the patient in the right time, give a good antibiotic, then the antibiotic comes down and the patient becomes absolutely normal, 95%. The remaining, yes, it can go on to the other one. They are usually preceded by acute infection in the throat or skin, pharyngitis or pyoderma, any skin problem. Most commonly, group A beta hemolytic streptococcal infection, as we know now. The nephrogenic strain is 1, 4, and 12. Remember this one, please. There are a list of these strains, but the nephrogenic strains are 1, 4, and 12. Complement level is low because it has been utilized in complement system. There is granular immune deposits in the glomeruli. Granular, why? Because it is forming antigen antibody complex and they are being deposited in the subepithelial area to form humps. So it has a granular deposit. There is subepithelial deposit of immune complexes appears as a hump. So I'll show you what is humps. Clinically, rising streptococcal antibody titer are identified in 80% of the patient, especially ASO titer, which is seen in streptococcal pharyngitis. And if the patient has bioderma, then you have anti-DNase B antibodies present. So either you have skin disease or pharyngitis. By this streptococcus, they can develop this entity. So clinically, the patient will have malaise, fever, nausea, oliguria, hematuria, and they will be having a smoky or polar colored urine. Why? Because the RBC usually they burst out and the hemocyte is being formed, so it is brown in color. 1 to 2 weeks after the recovery of the sore throat, so this is a time 1 to 2 weeks to develop antibodies. That's why it usually takes 1 to 2 weeks to development of the antibody, and these antibodies go and cross the skin. Clear? Red cell count in the urine, mild proteinuria, usually less than 1 gram per day, periorbital edema, and mild to moderate hypertension. So this is a specific, peculiar finding you see in clinically. In adult, the onset is more likely to be atypical. So this is typically of a child. It will develop like this. But in elderly people, it is little atypical, such as sudden appearance of hypertension and edema, frequently with elevation of blood sugar nitrogen. They might not have malaise, fever, nausea, oliguria, as we see in child. Important laboratory finding, as you all know, that there will be evaluation of anti-streptococcal antibodies titer, ASO titer, and along with the decline in concentration of C3. Why? Because C3 is being used in complement activation. More than 95%, recover completely after the disease. Small minority of the children, less than 1%, they progress and develop rapidly progressive glomerulonephritis, which we will be discussing now. Some of the remaining patients may undergo slow progression to chronic glomerulonephritis. Remember, each and every kidney disease ultimately, if it does not be treated properly, end up in chronic glomerulonephritis. Chronic glomerulonephritis. Prolonged and persistent the proteinuria, abnormal GFR, mark patient with the unfavorable outcome. Instead of recovering, when the GFR is declining, this shows unfavorable. It means if the patient is going towards rapidly progressive glomerulonephritis. Now, there are, as I said, other organisms which can cause same entity. Exactly, if you see as a microbe. Bacteria like Staphylococcus endocarditis, pneumococcal pneumonia, or meningococcidia, viral like hepatitis B, C, mumps, human immunodeficiency HIV, varicella infection or infectious mononucleosis, parasite like malaria and toxoplasmosis, or in this setting, granular immunofluorescence deposit and subepithelial humps, characteristic of complex nephritis after. Exactly the same as post-streptococcus. But we have defined you the characteristic post-streptococcus, but these all entities will show the same feature. The only thing is you will see hepatitis B subset antigen in those patients if it is by this one or hepatitis C antigen like this. Now this is a microscopic picture you see in this entity. So this is one biopsy, and you can calculate 1, 2, 3, 4, 5 kilometer lines. So as I said, you have to mention each thing separately. When you write glomerular line, you have to write, I have seen 5 glomerular lines. All of them are hypercellular. So you can see how much cellularity is there, right? All of them, not one or two. All of them symmetrically hypercellular. So this hypercellularity, either it is epithelial proliferation, the proliferation, or leukocytic infiltration. So it is a high power view of one of the glomerulus. You can see that all of the things are proliferating. X plus you have neutrophils. 1, 2, 3, 4. So neutrophils are also being accumulated inside the glomerulus. So this hypercellularity is increased by the neutrophils and some of monocytes. Clear? This is another picture. You see, all the glomerulus is in hypercellular. This one is also hypercellular with the neutrophils and other cells are proliferating. Now, immunofluorescence, when we do, you can see a granular. This is C3, this is IgG. Both of them is showing a granular starry sky pattern. This is typically known as starry sky. One thing I must tell you that when we do immunofluorescence microscopy, we had to have a dark room. So much so that we paint the wall black and we just close everything. We cannot even see our head. And then we put a light, immunofluorescence light, on a microscopic light, and then we see this greenish type of thing. If you have a slight light inside, you might not be able to see that. Okay? So you see such a starry sky pattern of glomerulonephritis. Now, electron microscopy, these are the humps. So this is epithelial cell and this is basement membrane. So it is subepithelial humps. This is high power view of one hump, right? So these are basically our deposits, immune complex deposits on the epithelial surface. Subepithelial hump. Clear? Yes.
What is the capillary?
This is this is endothelial cells. These are epithelial cells, and this is hump. This is podocytes.
So where would a self-endothelial lesion be?
Subendothelial will be here between the basement membrane and the endothelium. We'll come to it. Probably there are a few of the slides which shows that. Now prognosis, 95% complete recovery. Recovery rate is lower in precentric one because it is deteriorating, and in adult, 25% or more have a long-term sequelae such as persistent renal dysfunction and precentric. Now the same patient, as I said, 1% unfortunately will convert into a precentric one, which has not been given a full good treatment or it has taken a little longer time. Precentric glomerulonephritis. So you can see this is glomeruli and the parietal epithelium is starting proliferating and it is growing here. For example, as a pathologist, if I'm staying in a lab, no matter it's 10 o'clock in the night, and if I see that a precentric glomerulonephritis is developing, I will call physician or surgeon as soon as possible, the nephrologist. So please go and look at your patient. Probably by morning he is dead. So this is a medical emergency. If you see, listen, you have to call the physician as soon as possible. So there are three main entities like antiglomerular basement membrane antibody, number two, immune complexes which can go and demolish, and number three, anti-neutrophilic antibody, which is called ANCA. Very nice. And we have discussed ANCA already. How many types of ANCA? Two. C and P. Very good. Excellent. So there is rapid loss of renal function. There is oligonuria and anuria, hematuria and proteinuria, and crescent formation. All of them is now in upper level, not mild to moderate. If hematuria or proteinuria, severe. Crescent formation, more and more, right? Oligonuria and anuria, completely blockage. So this is how it starts. Starts from here, fluid. Then in the next phase, it is almost encircling. This is all parietal epithelium. Remember, visceral epithelium does not show this thing. Third one, it is almost has encircled the whole glomerulus and it is starting squeezing the glomeruli. Now the fourth one, almost it has engulfed the whole glomerular tract. Very bad sign. Recovery is almost negligible. If you have patient of this or this, you might save. But if it is just like this one, electron microscopy, you can see there is a disruption of the basement membrane, and you can see this is the basement membrane and it is disrupted. So there are three things, as we know: immune complex mediated glomerulonephritis, anti-glomerular basement membrane antibody, which is anti-GBM, or post-immune because of ANCA. Post-immune means when you stain, you hardly get any staining there. Three types. Granular deposit. So which of the things will show granular deposit? Yes, so it will be immune complex, right? Which will cause granular deposit. Linear deposit? Anti-GBM. Very nice. Anti-GBM. And minimal? Anti-glycogen. Right. So we have three different type of diseases, and this is what we get the picture. So this is the first pattern in which you see a granular deposit, which is immune complex diseases. So you see a starry sky pattern of the immunofluorescence. This is the first one. So immune complex mediated. It is caused by either SLE nephritis, acute streptococcal, IgA nephropathy, HSP, membranoproliferative glomerulonephritis, fibrillary glomerulonephritis, or many others. Okay? We take all of them. Yes. When you start understanding that these are all diseases, remember, there is only one disease, which is anti-glomerular. Only one. The other one is immune complex. So you have to remember only one disease, which is anti-glomerular, which shows a linear. Okay, clear? Now, anti-global basement membrane, you see, this is immunofluorescence, very linear type of deposit, very shiny, no granular one, right? So this is linear IgG, which you see in good posture syndrome. So it is anti-global basement membrane, which is limited to the kidney only. 30% of the patient will show only renal involvement. And some of the patients, which remaining patients, will show good posture syndrome. And what is good posture syndrome?
The body gets like more function.
So what else, what will happen?
The lungs.
Involvement of the lung. So the same antibody which is attacking the global basement membrane, the same antibody in good posture syndrome is attacking the alveolar basement. And what you see there? Hemoptysis and lung hemorrhage. Sometimes it is life-threatening, right? So the circulating antibodies are being there. And this is the last one, which is autoimmune, in which you hardly see any fluorescence one, which you usually see in ANCA-associated. And you all know there are three diseases: microscopic polyangiitis, which is PNK, vaginal granulomatosis, which is CNK, and Churg-Strauss. Churg-Strauss don't cause this thing, so you just remember these two: PNK, CNK, vaginal and microscopic polyangiitis. All of them now clinical features: hematuria, red cell cause, moderate proteinuria, occasionally reaching to the nephrotic range. Now this nephritic syndrome is converting into nephrotic one. Variable hypertension and edema. Now good posture syndrome, recurrent hemoptysis, and life-threatening pulmonary hemorrhage, which you see it. Good posture syndrome. So you have to treat this in a separate way. We will discuss. So to identify, we can have serum anti-EBM antibody, anti-nuclear antibody, NCA are helpful in diagnosis of specific type, PNK or CNK. So you will all perform these tests to diagnose which type of rapidly progressive glomerulonephritis you are dealing with. Okay. Now, recovery of renal functions may follow early intensive plasmapheresis. For example, if you have good posture syndrome and these antibodies are circulating in the blood, what you do plasmapheresis. You know what? How to do that? At one side you are taking out the blood, and from the other side you are putting new blood. So the whole body blood is being exchanged. So the blood which is having antibody is taken off, and a new fresh blood is taken in to help the patient, right? Some patient may eventually require chronic dialysis and transplant, particularly if the disease is discovered at a late stage. Once, as I have shown you the last picture, in which this crescent has almost collapsed the whole glomerular, then there is no chance of recovery. Then the patient had to go for dialysis. So this was all about any question?
Yeah, doctor.
Yes.
Why is there hypertension?
Why there is hypertension?
Yeah, what's the
Ah, I don't have any clue. But you have hypertension. Now this question, Dr. Khalid is coming. Ask this thing. He's a clinician. He will explain you how this hypertension is going. He is just coming now, right? Let's have your attendance, please. Stop.